Hi everyone, I'm going to talk to you about cord prolapse today. The risk factors of the cord prolapse are as such, so you can have a look. Mainly is like multiparity, abnormal line, low birth weight, preterm labor, polyhydramnios or the second twin is not delivered yet, unengaged presenting part, fetal anomaly, breed presentation, and also low-lying placenta. How do you diagnose cord prolapse? First, you can feel a pulsation of the cords when you do VE, or you can even see loops of umbilical cord in the vagina, or you suspect it when you have unexplained fetal distress or abnormal CTGs that you could see. The basic principles of obstetric emergencies are as such. So this resus mnemonic will guide you through over the few others tutorials about obstetric emergency. First, you need to recognize. Then you have to have early assessment. You need to stabilize and resuscitate. You need to have urgent management, and subsequently management will depend on each of the scenarios. So for cord prolapse, first you need to recognize this is a cord prolapse. How do you suspect if you have a patient with an abnormal CTG after STROM or after ARM? Then you look into the CTG. Is that there is fetal bradycardia or pathological CTG? Then you perform a VE and you feel that, oh, there's a pulsating structures. Or you can even see the loops of cord. Then you know that is a cord prolapse. So what do you need to do for early assessment? You need to assess whether the fetus is still viable or not, meaning that whether the fetal heart rate is still present or not. And you also want to know how far is the labor progress. Is it os fully already, or is it still 1 cm or 2 cm? Then for stabilization and resuscitation, first call for help. All right. When you call for help, you don't just call for help like that. You need to shout lah. Cord prolapse, you need to shout, and then you need to know, is this imminent delivery or non-imminent delivery? If it is imminent delivery, having to say that it is os fully already, and you can even see the fetal part there, then whether or not you want to proceed with immediate vaginal delivery, most of the time you will proceed with an instrumental delivery. But if let's say it is non-imminent delivery, probably 6-7 cm, then you and the fetal heart is still present, then you need to do some maneuvers to resus, to give the best option, best chance for the baby, meaning by elevating the presenting part. I'll go through with you about how to feel the bladder. Knee chest position. Pillow is you put a pillow underneath the buttock so that the gravity will pull down the fetal presenting part, or you can even put the patient in a Trendelenburg position. The pillow mainly is to put it in like a Trendelenburg position if your bed cannot be adjusted. So for urgent management is either you aim for delivery, either instrumental delivery or cesarean section. It's a category 1 cesarean section. Subsequent management or special referral or special measures is you need to actively manage the third stage. You also need to watch out for PPH. Why? Because as you can see, the risk factors for cord prolapse, for example, polyhydramnios, all are actually risk factors for PPH as well. Last but not least, you need to document, and you also need to debrief the family member, the patients, and also your team. So this is roughly how you should manage. First, you call for help, then you prepare for delivery. You want to prevent vasospasm by minimal handling of the cord. How do you prevent the cord compression? As I told you earlier, we will go through it in a while. One, elevate the presenting part manually with fingers, meaning that your fingers should be pushing the head or the buttock of the presenting part, not pushing the cord. Try not to touch the cord, okay? And number 2, you can fill up the bladder. 500 cc is quite a lot already, but you have to remember to deflate the bladder before you start to cut the skin during cesarean section. Knee chest position or left lateral. Knee chest position, we will show you the picture in a while. And last but not least, you can also consider tocolysis. Alright, if let's say you are in a district hospital that you cannot perform a cesarean section immediately and patient is contracting, you need to send the patient, let's say from Sri Aman, it's 3 hours away from SGH, then those kind of patient you need to consider about tocolysis. So let me go through with you about cord prolapse. So if you have a patient with cord prolapse, so first you call for help, then you have an early assessment whether the fetus is still viable or not. If the fetal heart rate is still present, is it an imminent delivery? Can you deliver the patient immediately vaginally? If yes, you proceed with vaginal delivery, and you most of the time it will be ended up with instrumental delivery. But if let's say it is not imminent delivery, you need to go for emergency cesarean section, category 1. So the maneuvers, a few maneuvers that you can do. First, you elevate the buttock by putting a pillow. Then you can feel the bladder. You can adopt a knee chest position or put in a Trendelenburg position. Or you also consider about tocolysis if you are far away. And remember, minimal handling of the cord. Alright. So if let's say the loop of cord is actually outside of the introitus, is outside of the vagina, what you can do is you use a warm pad and then you wrap it and try to put it back into the vagina. If you cannot put it into the vagina, it's at 30 cm of cord, so you just wrap it in a warm pad. So keep it warm to reduce the chance of vasospasm. Okay. So if let's say there is no fetal heart activity seen, then you need to ask, can this patient go for vaginal delivery? Meaning saying that is this a longitudinal line or is this an abnormal line? Abnormal line such as oblique line or transverse line. Oblique or transverse, you cannot deliver vaginally, right? So you need to go for cesarean section. But whereas if let's say it is a longitudinal line, either cephalic or bridge, you still can go for vaginal delivery. Other things such as is the patient 2 previous scar, 3 previous scar that are also considered not suitable for vaginal delivery, that you need to go for cesarean section. So this is how the outlines of management for cord prolapse. Okay. Last but not least, you need to document what has happened. Okay. So this is repetitive of what we have mentioned earlier. The thing that I would like to highlight to you is if you are in a remote area, all right, and you need to transfer the patient to a center that you can do surgery, you need to counsel the family member, you need to counsel the parents or patients that baby might not make it, or we might not have time, not be in time to deliver the baby. Okay. So this is how we talk about. So if you see the cord over here, and this is the head, okay, sometimes not the head, sometimes can be the shoulder or the bridge, the buttock. So when the cord came out, so your finger is to push the presenting part away so that you will not compress the cord. Not putting your finger inside the vagina and don't know where your finger is. So it's always pushing away the presenting part. Alright. So the idea of filling up the bladder is the bladder can push the presenting part away for you instead of you put your finger inside. Okay. Alright. So I also want to highlight to you, how do you fill up the bladder? So every time when we put in a CBD, the bladder will automatically be empty, right? So this is your IV drip set. This one you connect to a 500 cc of saline or water for irrigation. If you have water for irrigation, it will be best. If you cannot find a pint of water for irrigation, you can use a normal saline because it is just a temporary purpose. You must always remember to deflate it because otherwise it will crystallize and you cannot remove the CBD. Okay, so pay attention at this part. This is the place that you usually connect to the granula, right? So this is this part. What you do is, this is your catheter. This catheter head, you put it into the urethra and put it inserted into the bladder. Whereas this rubber tip is the place that you will inflate with 10 cc of water for irrigation to inflate the bladder, right? So that the bladder, the CBD, the catheter will stay in place in the bladder. So where should you put this IV drip? You should actually put this part into this part. Alright? So therefore, when you have this and this connected, you just need to lift up the normal saline pint, 1 pint normal saline, and you just squeeze and it will inflate the bladder by itself. Alright, so this is how you're supposed to do to inflate the bladder. Okay, so when you are in OT or while waiting to go to OT, you already finished pushing the 1 pint normal saline inside, you clamp and you change it to your CBD bag at the same place of A here. Okay, so when the surgeon want to start to cut the skin, you take off the rubber or you unclamp it so that whatever that has been inflated here can come out so that you will not injure the bladder during the cesarean section. Okay, so this is what we talk about knee chest position. So ask the patient to lie down like this. Okay, or you can, as when you do the VE, you need to push the presenting part, not the cord. All right, so that is what we need to do for cord prolapse. Okay, thank you.